Very good morning, everyone. Good to see all my teachers and friends at my working place. Uh, Today, I'll try to cover this topic of surgical strategies in GEJ cancers. So it's always a debatable scenario. So I collected evidences on basis of some evidences. What I got to know, I presented this, and seniors are there, so they can open for the opinion also. So coming to the gastroesophageal junction cancers, so these are rising incidence and because of GERD, and there are very aggressive malignancies, and there are very poor survival will be there. Coming to the classification, I think sir rightly covered all the topics like classifications like Nishi's classification and Siewert's classification and AJCC classification. Majority of the literature is around the Siewert's classification. I think the main flaw of the Siewert's is it will take the epicenter of the tumor, whereas for a surgeon it's more important is the proximal and distant extent of the tumor. So according to Siewert's, I know the type 1, 2, 3 will be there. And coming to the management, surgical management for a gastroesophageal junction tumors, always we'll decide the tumor into early stages or locally advanced or metastatic. Coming to the early stage, there is a lot of discussion in the morning. So majority are explored from the esophagus data. So T1A tumors limited to the mucosa and less than 2 centimeters with well differentiated will go for endoscopic mucosal resection or ESD. And locally advanced cancers, so usually that can be resectable or non-resectable cancer. According to NCCN, non-resectable includes the adjacent organs like involve the heart or great vessels or spleen and pancreas, and also different stations, nodal stations, like patient having a GE junction tumors with the left supraclavicular node that considered as a non-resectable cancers. And here comes the main role of a surgeon, where for all Siewert's type 2 and type 3 tumors, it is recommended that to go for diagnostic laparoscopy before any neoadjuvant treatment, because data has shown that there is 20% of some micrometastasis will be there in the omentum and peritoneum. So it's always wise to go for diagnostic laparoscopy for all the Siewert's type 2 and type 3 locally advanced cases. So coming to the resectable locally advanced cases, these are the trials already discussed extensively in the morning. So for a surgeon perspective, to decide what type of surgery to be taken, these are the parameters we take into the consideration. So like tumor location and local invasion and lymph nodal status and patient factors. Of course, the patient, whether it's fit for a major surgery or not. And of course, the main importance is the institutional experiences. So the key consideration for any oncosurgery is whether you are going to achieve that R0 resection and the extent of lymphadenectomy. These are the two very important factors which decide the prognosis for this, for say any cancer surgeries, and also surgical approaches. Coming to the margin, what I got data from the literature evidences is the NCCN recommends a minimum of 2 to 6 centimeters proximal margin. So the margin, majority of the times what we are more concerned is the proximal margin. That decides the treatment of how to handle the esophagus. So the Japanese guidelines will vary from 3.5 centimeters to the 6 centimeters for diffuse type. And this margin will depend on the tumor TNM staging also. If it's T1, there is the 2 centimeters required. If it is a T3 or T4 lesions, the chance of lymph nodal metastasis are more, so it requires a grade margin of 6 centimeters. So coming to the extent of a lymph node dissection, I got a good paper from Japan. So Osaka Medical University, it's a well conducted randomized study. There it divided into two groups into right thoracic gastroesophagectomy and transhiatal esophagectomy. They studied the mapping of the lymph node was done. So coming to the nodal status, it can be a mediastinal nodes or perigastric stations. And mediastinal can be upper and middle and lower station, that you can see that number. So majority of this, they subcategorize the lymph nodal chance of lymph nodal metastasis categories into 3 categories. Like the category 1 is showed in the red thing, and category 2 is the blue one. So category 2 is the chance of lymph nodal metastasis more than 10%. Whereas category 2 is 5 to 10%. You can see that majority of these GE junction tumors, the Category 1 nodes will be in and around the lesser curvature and at the origin of the left gastric artery. So whatever surgery you do, so better, and majority of the G2, Siewert's 2 and 3 have this type of lymph nodal stations, whereas Siewert's type 1 has a more of a upper mediastinal thing.